So my name is Joel Franck. I'm a neurosurgeon at Panama City, Florida. You should all come to Panama City Beach. It's the most beautiful beach in the world, and it's where spring break is, which is a few months that we dread as neurosurgeons. But I began work on C1-2 because of an association with a chiropractor named Mike Smith, who introduced me to two modalities. One, the most important modality that we're talking about today, the Fonar upright scanner, and another called digital motion X-ray, which I'll show you in a minute. But first of all, I want to thank Dr. Damadian for this conference, and I had a personal experience with him, which is when I was at Rockefeller University as a graduate student, a friend of mine invited me down to downstate where Dr. Damadian was working, and we walked to visit his laboratory, and I wandered through and met Dr. Damadian and saw him, this tall, strange guy with bubbling wires all over the place. I had no idea what he was doing, and what I witnessed was one of the first MRI scans ever done on a mouse. And I saw a year later, the cover of Science magazine, and I said, oh my God, I can't believe I didn't realize the significance of it. And it's just so meaningful for me to meet him again after all this. This all began, there was a patient in Tampa, Florida named Amanda Bennett, and she was in an accident, and she was a beautiful girl, a runner and a banker, and she developed a whiplash, she had a whiplash, and her life went to crap. And she went from doctor to doctor to doctor for 5 years. They told her she was crazy. And then because of this association with Dr. Smith, the patient came to me, and we devised an operation, and she got better, and then the word spread, and we've done about 50 patients from all over North America. So let me explain to you what this is about. It involves, first of all, this is from a lecture that's a year old because I wasn't prepared for this, but we just have more and more data. And what we do is let me just get to this. We look at both the Fonar scan and at a video fluoroscopic view of the patient with an open mouth view so we can watch lateral movement of the C1 on C2. First of all, with the Fonar scan, most of these patients end up having, this is a normal alar ligament. Most of these, and I'll show you a couple of abnormals quickly, but most of these patients can be detected to have either a clear abnormality of the alar ligament or of the transverse ligament that accounts for lateral slippage. Additionally, what's very important, and this is something I'm really gratified to be here to understand this because I didn't before. I'm seeing more and more patients with this Arnold-Chiari syndrome, and I'm wondering, this is crazy. And now I'm getting an understanding of why it exists, and what's very important about it is not only is there a crowding because of the Arnold-Chiari, but there's also, with these patients, a capsulosynovitis. What happens is normally the posterior longitudinal ligament should be flat, more or less, against the odontoid. But these patients, because there's lateral movement, get an expansion of the odontoid. It's almost like, it looks like a rheumatoid arthritis pannus. And then they get this compression such that if you can imagine this patient now flexing their neck, and you could see this, that there's a compression of the brainstem, which accounts for why these patients have all these weird symptoms. It's not a single area that's being affected, it's the entire brainstem and cervical-medullary junction. So what we do, the first test is a digital motion X-ray. So here's some stills from it. And what we can see here, for example, is that normally when you tilt your head laterally, C1 should not move on C2. It's a rotation. The ligaments cause it to be limited to a coupled rotation. Well, look over here at this patient. This is an overhang of probably about 7 or 8 millimeters of C1 off of C2, and similarly on this side. Okay, and that is clearly pathologic. There's been work that's showing that the normal is 1 to 2 milligrams. 1 to 2 millimeters. Wait, I just want to, how do I go back? Oh, previous, 1 second. I don't know whether this will, so if I hit this click here.
Go back again, and then come back.
If I click, no, it's not working then. Okay. Wait, let me see. There's a video embedded. Let's see, but it may not play because, Wait, go back, keep going back one more time. One more. There. So it won't play? Okay. Well, anyway, basically what you see is with the open mouth view, you see this rocking, and these are just frozen sections of it. And this is the key to understanding the pathology. And then underlying it, we then do the Fonar scan and find that almost all of these patients, something like 80%, have a clear ligament injury. So what do we do about it? What we do is something called image-guided surgery. So this is a device called the Stealth. It's a commercial. It was invented by a good friend of mine named Rich Buchholz, University of St. Louis. I knew him when we were med students at Yale. And he developed this in his workshop at home. And basically, this is a radar system. This emits infrared light and reads infrared light that's reflected off of certain devices. And this is a high-speed computer that's put at the patient's side. This is called the O-arm. It's a intraoperative CT scanner. It opens up and comes over the patient with this great Star Wars sound, and it takes a CT scan. Now, what happens? How do we integrate all this? These are devices that are used during surgery. Notice they have these reflective balls. So this is a drill guide. This is a pointer. And notice how they're all shaped differently. Okay? So what happens is, the patient is put to sleep. They have a head clamp put on them, so they're in the prone position. It takes about a half an hour to position them properly to get an angle that allows us to get a screw in very accurately into C1 and C2. This is a frame that's affixed to the patient's head, and it has some balls on it. Actually, I'll show you that quickly. Right here, that's the frame. This is we make two small incisions. They're stab wounds at the base of the spine, and a very small incision over C1, C2. Let me go back now. So what happens is that stealth device, the radar device, sees the frame. It sees the frame, so it knows where in the room in physical 3 dimensions the patient is, because the frame's hooked to the patient. It also sees the CT scanner. It knows where it is. So when it takes a 3-dimensional image, which is what a CT scanner does, it knows where that image is in real space. So it knows where the patient is, it knows where his or her spine is. And therefore, when we move this instrument in real space, it knows where it is in real space, and it could project it on a video screen. So this is how this works. So the patient is lying here, and then what we do is we take a 3-dimensional view and we put it on the Stealth screen, and the Stealth is right in front of me. And so we have to angle the screw to get between C1 and C2. The screw is made out of titanium. It's 4 millimeters long, 4 millimeters wide, and about 34 to 42 millimeters long. And the idea is for it to hook C1 to C2, but to avoid hitting the spinal cord and avoid hitting the vertebral artery. And so we then measure, this is all a simulation while the patient is asleep. We then measure the length of the screw, and which it tells us right here, and then I'll show you in a minute. We then put in the screw, and we do another O-arm image. It's called a spin because it sounds like it's spinning. And we know that the screw is in the right place. And then we repeat that on the opposite side. And then the surgery, and then we have to put a little fusion bone in, because if you just put metal in the spine and no fusion bone, the metal will erode. So we actually have to put some fusion bone in. So now I'm going to show you the movie. How do I do that now? Yeah, it was up. Yeah, yeah, we have to. Okay. Yeah, this is it. Okay. This is a 2.5-minute summary movie of an operation that takes about an hour and a half. Spinous process, the dorsal spinous process is C2. C1 you probably can't see from that angle. This is the incision right under the base
C1
of the skull.
Has some ability to rotate laterally and move laterally. This is completely loose. It's as if there's a fracture, which there is not. It's just that the ligaments are totally unstable. And not so much in flexion versus extension, fortunately. 38 is going to be the screw length. And then the length of the drill The blue is the actual probe, and the yellow is just simply a measurement extender. Now, I'm going to take this drill guide, target, and feeling to make sure it doesn't hurt the cell to get the ideal orientation before drilling and putting in the screw. So this is a perfect trajectory. Can you hold the wooden hand?
See, I'm more focused on this screen than the patient because this is the key to the procedure.
Screw in place. And now we're going to take another spin. I can feel C1 being pulled towards C2, indicating that it's locking in. Look at this. You see this? I can't move this now. So we're now about to do an O-arm spin. What you see here is a three-dimensional, what's called multiplanar reconstruction. You can see the screw on our right, which is the patient's left, and it's essentially perfectly placed. See the drill tip? Keep looking at it. C2, and they are lock solid, and there's no lateral movement whatever.
Our 3D reconstructed image, we like to call it the ghost view. We're able to rotate this image in any plane. AP, PA, we're able to do obliques. We can turn it on end, get a nice axial shot, and actually look down on the spine where the spinal canal would be, proving that the screws are not in the spinal canal.
So let's go. I'm going to go to the next. We've done about 50 patients. These patients, it's a one-night stay in the hospital. They have to wear a collar for 6 weeks, just like any cervical fusion. Most of them, there is a little discomfort because of the incision in the back, but when they wake up, they've come in with these unbelievable headaches. That's the key syndrome, is a post-whiplash migraine headache. And many have all these accessory symptoms that are listed beautifully in that monograph summary that Dr. Damadian handed out. Their symptoms are gone. I mean, it's just unbelievable. And similar to the story that Christine told about the mechanical way of doing this. And here's a brief two-part interview. I apologize for the little egotism in the interview, but
between a local neurosurgeon and a chiropractor has led to major pain relief for accident patients.
One teenager even traveled from Utah to see if it would work for her. She had actually become a prisoner to her pain.
I mean, I'm leaving for college in 3 months.
A year ago, 18-year-old Danelle Devine couldn't imagine being able to walk without assistance, much less go to college. The competitive ski racer was in so much pain she could barely get out of bed.
Talked to my physical therapist, and we tried taping my neck. We tried injections. I don't know. We went to a migraine specialist and a neuro-ophthalmologist. And over that summer, we tried to figure some stuff out, but nothing was really working.
The pain started when Danelle broke her back at the age of 12 during one particularly hard fall while skiing. She didn't fall often, but when she did, she fell hard.
After my concussion in December of 2010, things just never went back to normal. It just became clear that something was really, really wrong.
During a summer ski camp, her vision went blank, causing her to black out and fall. Danelle went in search of help again.
And we went from doctor to doctor to doctor to doctor, each of them saying, like, oh, we can't help you, go see this guy. Oh, we can't do anything for you, go see this guy. Oh, sorry, I don't know what's wrong, go see him.
Nothing helped ease the pain, and Danelle found herself unable to do the most mundane, everyday tasks.
I was pulled from school because it had worsened to the point where I couldn't read without throwing up, and I couldn't really walk very well by myself.
Danelle ended up in the hospital in November of 2011.
And when we were there, I mean, nothing was accomplished. It was just from doctor to doctor and test to test.
Danelle's physical therapist started doing some research and came upon an article written by Bay Medical Neurosurgeon Dr. Joel Franck. A call, then a visit to his Panama City office gave her hope that finally something might be able to help.
Medical Minute, brought to you in part by Bay Medical Center.
And Dr. Franck says his expertise in neurosurgery coupled with a high...
Whiplash is a common injury after accidents like car crashes. Well, for most, the pain usually goes away with proper treatment.
But for those who can't seem to find relief, two local doctors may have come up with a solution. One has a unique x-ray machine. The other uses the results from that machine during surgery. Sudden collision on the highway or the sports field can be hard on the neck.
And when these ligaments are injured, a level of instability or slippage comes in.
And it can cause a lot of pain.
And the symptoms are akin to a migraine headache.
18-year-old competitive ski racer Danelle Devine can relate to that type of pain.
And my physical therapist the whole time was saying, you have an instability in your neck.
After years of debilitating pain, Danelle finally found a doctor who believed her.
And they're not nuts. These patients have a legitimate problem.
Bay Medical Neurosurgeon Joel Franck discovered a way to determine if a patient's pain was connected to the upper cervical spine. He uses a unique x-ray machine at Waterside Chiropractic called Digital Motion X-ray.
The patient basically has a video taken of their neck in motion while under x-ray conditions. And we're able to see in this very unique study
I don't know if you can catch
that
the slip right there.
ligaments are injured.
Dr. Franck describes the surgery as simple but very high-tech.
This is completely loose. In the back of the neck, make a very small incision and look at the first and second cervical vertebra. And then utilizing a radar system that guides me, my hands are almost as if they were a robot hand. I place a very small screw.
Dr. Franck guides the titanium screw through a small incision above the shoulder and into the upper cervical spine.
We close up the wound. Patient goes to the floor and goes home the next morning and wears a collar for 6 weeks until it's fused.
Devine had the surgery last December and finally has her life back.
I don't think I had ever really realized like the depth of my symptoms, because I guess I'd just been living like that for so long that it had become like my reality, I guess. I don't know where I would be if it weren't for Dr. Franck.
So, and one other comment. Because
know if you're...
one other comment. Because of my realization that so many of these patients have this Arnold-Chiari type of syndrome, I began doing a small craniectomy in addition, which takes about 10 minutes, just taking out a centimeter by a square centimeter or two of the base of the skull, and to decompress the cervical medullary junction, and basically it's been terrific. So, and right, thank you very much for being here. Thank you.